Good afternoon and welcome to our Orthopedic and Sports Medicine lecture series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you have the ability to ask questions via the Q&A feature located in the bottom of our screen. I will be your moderator in today's lecture. This afternoon, I have the pleasure of introducing Dr. Rafael Diaz-Garcia. His presentation is titled TMR and RPNI, the alphabet soup in the management of neuromas and neuropathic pain. Dr. Rafael Diaz-Garcia is a board-certified orthopedic hand and upper extremity surgeon with Baptist Health Orthopedic Care. He specializes in peripheral nerve surgery to treat neuropathic pain, nerve compression, nerve laceration, and injuries, as well as brachial plexus pathologies, including neurogenic thoracic outlet syndrome. In his clinic, interest includes the care of high-level athletes, orthopedic and orthoplastic of the hand and wrist, arthritis, spasticity, treatment of rheumatoid diseases, and microsurgical treatments of vascular insufficiencies in the upper extremity, among other types of conditions. Dr. Diaz-Garcia earned his medical degree at the University of Pennsylvania School of Medicine and a master's degree in healthcare management at Johns Hopkins University Carey Business School. He completed a general surgery internship and a plastic and reconstructive surgery residency at the University of Michigan Health System. His postdoctoral training also included an orthopedic hand and upper extremity surgery fellowship at the University of Pittsburgh Medical Center. Prior to joining Baptist Health, Dr. Diaz-Garcia was the Director of Medical Operations and the Chief of Plastic Surgery at Allegheny Health Network in Pittsburgh, Pennsylvania. He also served as a clinical associate professor of plastic surgery at the University of Pittsburgh School of Medicine. Dr. Diaz-Garcia was one of the pioneers in using targeted muscle reinnervation for the management of neuromas and phantom pain in patients with limb loss. He has more than 10 years of experience using this procedure and finds it extremely gratifying to provide pain relief to patients who have had or have been told there are no options. Castle Connolly has recognized Dr. Diaz-Garcia on its list of top doctors. He serves as a reviewer for the Hand Journal and regional editor for the Journal of Hand Surgery Global Online. His work in orthopedic and hand surgery is widely published in peer-reviewed magazines throughout the world. He frequently lectures on the management of nerve injuries in the upper and lower extremities and limb salvage after trauma or cancer. Dr. Diaz-Garcia is a fellow of the American College of Surgeons and a member of several professional organizations, including the American Association of Hand Surgeons and the American Society of Plastic Surgeons. It is my pleasure to welcome you, Dr. Rafael Diaz-Garcia, to this presentation. Thank you so much for making the time to share with us your knowledge. The floor is yours. You may begin your presentation.
Thank you so much. I appreciate that introduction. Hopefully you guys can see my slides. The reason I kind of chose this as a topic of discussion is I think that there's a lot of need for management of pain. I think that as we look at the landscape of medicine, pain is kind of one of the last frontiers where a lot of people are suffering without necessarily good options. And I think having the discussion here is of use. Hopefully we can kind of brainstorm together with new options for all of us.
Dr. Garcia, please try again. It hasn't projected.
Oh, I'm sorry.
It's okay.
As I
Now, in presenter's view. Perfect.
So, as I was trying to say, the title of this is just because there's a lot of different people discussing TMR and RPNI, for those of you taking care of neuropathic pain. And I kind of want to just kind of give you my view of it and my landscape and answer any questions about, what patients may benefit from this. But in general, for neuromas, I wanted to discuss what we've been doing for the last 100 years of management and why that doesn't make any sense. What are the current treatment options that have really been adapted over the last 10 to 15 years? And what are some options that we may know in the future? So limb loss is something that people suffer with around the world. In the United States, we have about 1.7 million to 2 million people who suffer from upper and lower extremity amputations, although the lion's share are seen in the lower extremity. And they may be from traumas or vascular disease, diabetes mellitus, and cancer. And obviously, this is not only a devastating event for the patients in terms of function, but ultimately, for their quality of life. Across the globe, it's a much bigger problem. You see, particularly in China and Southeast Asia, where there's a much bigger motorcycle and the moped culture, that we're talking about tens of millions of people that are suffering with limb loss. And the biggest thing that people don't talk about, whether they be on the orthopedic surgery side, in trauma, or in the physiatry side, after placing prosthetics, is that even if they're doing pretty well, a lot of them have pain, and they kind of learn to live with pain. I break up these pain into two different things. One is residual limb pain. So this is pain with direct palpation of a specific portion of their residual limb or extremity, versus phantom pain, the pain of the limb that's no longer there. And the reality is that only about a quarter of patients who've had an amputation, and I say major amputation, more than a digit or a toe, have a pain-free life. And ultimately, the majority of them are living with moderate to severe pain. When we taking a step back to looking at just the progression of prosthetics, nothing's really changed very much. So this is a photo back from around the Civil War. You have leather, some steel. They haven't really got any good joints yet, but overall, it's biscapular motion that's driving the motion of these prostheses. You fast forward to the 1960s, so 100 years go by, and a little better fit, a little better products. Now we have cables and elastic bands that can help with a little bit more prehensile function. And now you have some articulating joints at the elbow that can be turned on and off, but still really just leather and cables. And looking now, nothing's changed for the average patient. But we have robotics, right? This is the 2024, and we have these amazing robotics that exist and can have 21 or 23 degrees of freedom, almost mirroring the function of the hand. But it's similar to having an Apache helicopter and trying to drive it with an RC controller. There just isn't enough fidelity of signal and enough control to be able to do it safely and functionally. I won't go into all the different discussions of where to control prosthetics, but people have talked about, could you control a prosthetic with the brain directly and put electrodes there? Can you do it in the spine? Or can you do it peripherally? And they each have their proponents and people who make an argument for it. But ultimately, I think most people feel that the peripheral prosthetic control makes the most sense for a lot of biologic reasons, because the signal's right, is right where you want it to be. It's amplifiable and can control, a prosthesis through signaling. When a nerve is cut, whether it be a laceration or an amputation, the downstream nerve begins to degenerate and disappear through a process called Wallerian degeneration. Then a growth cone develops in an attempt to recreate those nerve fibers. And as it's growing, that signaling distally kind of directs the nerve to go back to where it was before. If the two ends are close to each other, the nerve will find its way. However, as you continue to see more and more nerve fibers, if there's nowhere for them to go because there is no nerve end, because it wasn't repaired, or if it was a large injury, or there was an amputation, you get a nerve tumor. And this nerve tumor is essentially a benign mass that every nerve injury has, if it's not repaired, and we call it a neuroma, but it's functionally just a fibrotic nerve tumor. And why do we care? Well, they cause pain and they make it difficult for people to use their prostheses. So these are two patients. One on the left is swollen tibial nerve, which is a neuroma in continuity after a gunshot wound. This is after an amputation. You have this big nerve tumor involved in scar as a result of the amputation. The history of neuroma surgery never really made that much sense. So this is a Morton's neuroma. This is a non-traumatic kind of repetitive neuroma develops in the feet of patients. And the treatment was to excise and just cut out the neuroma. The idea, though, that you can have a neuroma, a cut nerve develops this nerve tumor, and then you're going to shorten the nerve and then expect something different to happen. You're just getting another neuroma now at a different level, at a shorter level. And Albert Einstein was famous for being told that insanity is doing the same thing over and over again, expecting different results. And that's really what the first 100 years of neuroma surgery have been. If you don't change the biology, you're going to end up with failure because you're going to get the same results over and over again. So some mentors of mine, Greg Dumani on the left and Paul Sturner on the right, these independent thinkers and really kind of on their own path found a similar solution kind of accidentally. So Dr. Kaiken and Dumani were looking for prosthesis control using bigger nerves. Dr. Sturner was looking at smaller nerves and putting grafts of muscles onto nerves to see if they could control prostheses. But ultimately, what they found was that while they were trying to get prostheses to work, that their pain got better. It was completely incidental. They were not trying to do this. They were trying to do a functional operation. What is TMR? So targeted muscle innervation is where you take nerves that have nowhere to go, reroute them to muscles that are still present. And what that does is it gives the nerve something to do. That downregulates all the growth factors that create the neuroma and downregulates the central nervous system from developing or continuing to have phantom limb pain. These are kind of some patients of what you see. So this is a trans femoral amputation in a delayed fashion. And so we find these nerves that are long and have nowhere to go and have these nerve tumors. And we find motor branches that are going into muscle, and we essentially cut the nerves and reroute them. So now instead of being a nerve to nowhere, it's a nerve that's been coapted and repaired to grow into and heal into a muscle. The effects are actually pretty amazing. So this is a video. I don't know if the audio will play, but I kind of just want to describe it. But this is a patient who had a high, four-quarter amputation, who just after TMR, after this is healed several months, can control a myoelectric prosthesis with almost no training because it's just intuitive. You think, I want to open my hand, and a muscle contracts. You think, I want to close my hand, a muscle contracts. You don't have to move your shoulder blades apart in kind of an unnatural way to be trained to do the functions. All we're doing is creating new amplification points for those nerves that have nowhere to go. So as I was mentioning before, benefit of TMR is that now you don't get a terminal neuroma because the nerve has somewhere to go and something to do. You get downregulation of pain in the central nervous system because of the feedback that nerve is not searching for some type of signaling. It helps in myoelectric controls of prosthetics, which was the ultimate goal. But again, I think that the use of pain, particularly in lower extremity amputations where you're not trying to get higher level prostheses, is super helpful. And I think has really become the main reason we do this operation. Well, does it even work? I won't go through all the papers, but paper after paper has shown that it improves task efficiency for patients who undergo nerve transfers and end up with a prosthesis. Their neuromas don't come back if they have TMR, and that their phantom limb pain significantly improves if it hasn't been present for a long time. My experience has been that patients who have this surgery within 6 months or a year of their amputation do a lot better than people who have kind of established phantom limb pain of 5, 6, 7 years. It doesn't mean that those patients with longer term symptoms don't have options, but they're just less predictable. this is just looking at the general population on the right versus patients who've had TMR. And so the general patients, their worst pain's a 5, and their current pain's a 1. The worst that their pain, a TMR patient, is 1. So they're not pain-free, but they're significantly improved. The neuroma pain, that residual limb pain, the worst that the TMR patients is F1 versus those that have traditional neurosurgeries are 4s. An RPNI is essentially just a microscopic version or mini version of TMR. We're taking small muscle grafts, we're incorporating them, and I don't want to get into the weeds of why there are some benefits for this in certain studies, but the reality is that, again, if you give the nerve something to do, you don't even need a full muscle. If you give a little bit of muscle there, it'll grow into that, it'll reinnervate it, and they won't form a neuroma. This is a neurotization model. So, again, previously a nerve would get cut, it would be placed into muscle blindly and say, oh, that'll get better because it's away from the edge of the skin. It just forms a neuroma at a deeper location. But if you give it denervated muscle, so the muscle no longer has a signal, that muscle will send out signals asking for that nerve to create new neuromuscular junctions. And those neuromuscular junctions are what then create the environment that prevents neuroma formation. This is kind of what it looks like intraoperatively. So you have a nerve on one side, you have a graft of muscle that gets wrapped around almost like a burrito or an empanada. What happens over time? So this is in a rat model, but you can see that a year after these implantations, that comparing the muscle that was grafted onto the nerve versus the control muscle, that there's a reduction in bulk about 20%. There's also a reduction in contraction about 40%, but they don't develop these neuromas, so their pain is improved. And you can see that they still contract. So this is a control. On the left, you have a patient, not a patient, but a rat with peroneal and tibial nerve EMG during their ambulation. And on the contralateral side, you have the nerves were cut, muscle grafts were wrapped around them, and then you see that they'll contract along an ambulation phase, very similar to the contralateral side. So even though they're not normal, they don't contract normally, they will promote the same signal. And this is a patient of mine. So this is he was about 2 years out from a traumatic amputation of a fingertip. You can see here, he had these painful neuromas at the tips of his fingers, which were causing difficulty for him to use that hand. So he was bypassing that finger and not using it. And so what I do is we cut out these neuromas, take a small 2 by 1 centimeter graft from his forearm. We cut it into small ribbons and we wrap them around the nerves, allow the nerve to innervate that and downregulate that signal so they don't develop symptomatic neuromas again. So should everyone get a TMR and RPNI? To be honest, we don't know. I think we favor doing it on more patients than not because the downstream effects are so helpful. But the reality is that certain patients, the neuronal pain and phantom pain is so much better. Upper extremity patients who have amputations at high levels, for sure. Traumatic patients who are younger, that don't have diabetes, don't have vascular disease, are some people who should consider it. And same thing with oncologic patients who don't have diabetes, who don't have vascular disease. People with poorly controlled diabetics, they often have some element of neuropathy, which kind of confounds the picture where they may have some pain that's more from the neuropathy, not necessarily from a neuroma, and it's difficult to kind of to split that out. But ultimately, 25% of patients are going to have chronic localized pain in the residual limbs if we don't treat their neuromas, and they do better if we get to those patients earlier rather than later. So hopefully, I tried to kind of get through a lot of information in a short period of time, but I hope that you guys walk away from this understanding that pain from nerves really affects a lot of people, particularly those who suffer some type of amputation. It affects their quality of life, but also affects their ability to use prostheses and affects their ability to interact with the community. And that TMR and RPNIs are these novel solutions to these difficult problems that for a long time we just ignored, but ultimately can do better if we address them early. And I hope that you think about this as an option with acute patients who have amputations or patients who have failed to reach goals within a reasonable time. And 6 months, 8 months out, you think maybe they're a candidate for something else. And I really thank you for your time.
Dr. Diaz-Garcia, thank you so very much for this brief synopsis of all the incredible things that you do for our patients, especially those individuals that are seeking some kind of a relief from pain, as you described it. It is mind-boggling what you guys have accomplished in the past 20 years in regards to these functions of these limbs that are created in laboratories practically to aid on the patient. You did mention incredible things here, and I want to make sure that I recapitulate this accordingly because we do get a lot of requests. And I am so happy that you are already in our Center of Excellence in Orthopedics, because I think you're going to get a huge international following eventually. But one of the most important components is here, obviously, it is the pain. These individuals that have suffered already amputations, they're constantly complaining of pain and they do not know what to do about it. And of course, they're referred from one specialist to another, and they might not necessarily get the relief. So this thing about reducing pain by allowing the neuroma to disappear and using the targeted muscular reinnervation, I believe it will be a game changer in the future. Now, doctor, on these particular amputees that you treat, are they freshly amputated, or can anybody with a chronic amputation come to you and say, I need to be considered for a limb?
Yeah, so anyone can be considered. The work out of Northwestern showed that in Ohio State that people who have them within 6 months tend to do better than people who have waited longer. But I had a patient when I was still in Pittsburgh who had this, she was a young mother, had had a complication, ended up having a intra-aortic balloon pump, complication from that, ended up losing her leg, and she was on methadone, really high level narcotics for years. She was 7 years out. And about 6 months after I had done her TMR, she was off all narcotics. She still had some pain, but it had been life-changing for her. We've also had patients who are 4 or 5 years out who don't get a ton of relief. So the longer you wait, the harder it is to know what kind of benefit you'll see. It's rare that you'd get worse. Usually see some relief, but whether or not it's going to be worth it to you, it's tough to say. But ideally, getting patients who are under a year is ideal.
Now, one thing that is always mind-boggling, it's how patients that receive this type of limbs can actually start using them, as you demonstrated in the video, almost without coaching because it is intuitive. Can you recapitulate and actually briefly mention how does this work in essence? Because obviously you're thinking it is an automatic process to lift a cup or to do something with your new arm. But how does that in essence work?
Sure. So right now, when you move your hand, you're not thinking about specifically moving your hand. You just do it, right? So you go to move your thumb, a signal from your brain goes to your spinal cord, comes down your nerve, and your muscle contracts. When you cut the nerve and the nerve is no longer connected to the muscle, that signal is still there. When you think about when amputation patient thinks about moving their thumb, even though their thumb's not there, they're sending that signal, but it's not going anywhere. It's the middle of, essentially going into space. By rerouting that signal now to a muscle that's been denervated, that signal will then be sent down. It'll cause that muscle to contract. And we send them to specific prosthetists that will map out their chest or their arm, whatever residual limb they have, to pick up the signals where now these new muscles are contracting. They map it out on a computer program, essentially put that program into the software of the limb, so that now when you say, I'm going to move my thumb, that little piece of muscle contracts. If the EMG off of the device picks it up and then moves the robotic arm.
Wow, that's simply amazing. And then you did mention that depending on the schools of thoughts or how you would determine which kind of prosthesis you're going to use on the prosthetic you're going to be using on the individual, Do we still think of actually using any of the brain channels to do this, or is it more on the shoulder side?
Yeah, so the problem with using like ECOG or some type of intracranial signaling is that it works really well for a while, but then you get a lot of scarring and you lose the fidelity. It's been kind of the issue that's happened whenever they've tried to put signals to type of conduction signals, whether it be in the nerve, around the nerve, in the spinal cord, in the brain, is that it works for a while, looks kind of favorable, but over 3, 4, 5 months, you lose that signal, you lose the resolution, and it doesn't work. The benefit is that the nerve grows into the muscle, and that's a natural relationship. It's a symbiotic relationship between the two, and so you don't lose that signal over time. It maintains fidelity over years.
Wow. And then one final question, doctor, and it has to do with the fact that obviously now the patient has gone through the entire process of being a candidate, selected to be the recipient of this device. And how long do you typically expect for these individuals to feel fully proficient in actually managing their new limb? And how long is it good for?
So in terms of how long it takes, it really depends a lot on the level of amputation. So the higher the level, the more nerve transfers we have to do, the more they have to map. And nothing is going to recreate a normal limb for them, right? So if you have a four-quarter amputation through the shoulder, there isn't a lot of muscle left to power the signals. So it's a lot harder for us to be able to kind of get the degrees of freedom with different contractions. Versus a transradial or through the forearm, you have a lot more options, a lot more signals you can kind of control. So the training part is done by the physiatrist. They do an amazing job here. And that can take, it's easier than it is with a mechanical prosthesis, because there you have to kind of do, abnormal shoulder motions to try to get the prosthetic to work, versus this is much more intuitive. But you do have to kind of learn where, how much to contract to be able to, because you don't have sensation there. You're trying to get that signal. You have to kind of get used to how much you can or can't do with that hand. And then even when you're not doing prosthetic control, which is really for upper extremity, amputations, for lower extremity amputations, just the neuroma pain, management of, the discomfort and the ability to use prosthesis, irrespective of their reconstructive options for the prosthetic, I think are valuable.
Absolutely. Dr. Downs has a comment, actually a question. It says, is it practical to perform this on elderly, for instance, 80 or 90-year-olds?
Yeah, I mean, I think it's an interesting question, and I think it depends on what they need an amputation for. So if you gave me an 80-year-old who has vascular disease, there's evidence out of Michigan that those patients do worse if you try and do it, because the planes you have to create increase your likelihood of wound infections, increase your likelihood of complications. If it's somebody who is a poorly controlled diabetic, my experience is that those patients don't usually get symptomatic neuromas, even though they may have neuromas there. But if you had an 80-year-old who was running marathons and was otherwise healthy and had an injury, I think you have to treat that person not chronologically as 80, but physiologically. So if they're otherwise like a 50 or 60-year-old, but just happen to be 80, I think that's someone to have a conversation with. And again, it doesn't mean that you have to do it at the time of amputation, which I think can be helpful if you have that team together. But you give them 3 to 4 months and let them rehab and see if they're into their prosthesis. And if they're doing 90% of what they want to do, then maybe they don't need anything else. But if they feel like, I can only wear my prosthesis for a couple hours a day, I find myself being at home more and more, I feel more, ostracized or secluded from my community, there are options for them.
And the opposite spectrum, obviously, in pediatrics, do you guys consider pediatric patients for this type of procedures that obviously eventually will need to be changed?
Yeah, so they do. I don't personally do them, but I work with surgeons at Nicholas here in Miami that do offer those operations for oncologic patients and traumatic patients.
Wow. Well, this is absolutely phenomenal that we have you in our team, Doctor. Welcome once again to the Orthopedic and Sports Medicine Institute. We are honestly very honored to have you. Thank you so much for your presentation, and I want to thank everybody that participated today for your attendance. If you do have additional questions or you're curious about other types of procedures that Dr. Diaz-Garcia has in his tools and armamentariums, please feel free to send them to us at BHIWebinars@baptisthealth.net, BHIWebinars@baptisthealth.net. We'll make sure to pass along your questions in order for him to elaborate. And if you do want to see him directly, please contact us directly at our International Services Department for us to be able to assist you. We look forward to seeing you all during our next Orthopedic and Sports Medicine lecture series. This time is scheduled for Wednesday, November 13th, 2024. Thank you once again, and have a great afternoon. Thank you so much, Dr. Diaz-Garcia.
Thank you for your time. I appreciate it.